The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day, good morning, good evening, good afternoon, depending on when you're watching this. We are gathered for the next episode of TMD Demystified, and I am Tony Urbanic. Today's episode is going to be a little hard for me to deliver. I had thought considerably about presenting this episode, and this morning finally decided to go ahead with it. The title of this episode is The Ultimate TMD Patient. The Ultimate TMD Patient. And in a few minutes, you are going to find out all about the ultimate TMD patient. I hope you bear with me. This, again, is an important episode. The last episode I did was entitled The Angry Patient in TMD, and in that I described a specific patient that I had in that week that entered the practice extremely angry, and I was able to handle that patient nicely, and the patient accepted treatment. And go back and read and review that episode if you'd like. I thought it was a pretty good episode, and there's something to learn from that. That's why I do these episodes. I hope to teach you something based on the tremendous knowledge that I have acquired since entering this rabbit hole 12 years ago. And I call it a rabbit hole, and it has been. You know, you get down far enough and it takes another direction, and it takes off in a whole other area. While I practiced oral and maxillofacial surgery on the temporomandibular joint, my life was pretty simple. You know, I did what the textbook said. I did what my colleagues taught what the oral and maxillofacial surgery textbooks and others said was the right thing to do. And basically, it got me nowhere. It got me to the point where only 50% of the patients were helped, the other 50% were not. And that's when I quit doing temporomandibular joint surgery 12 years ago. But since then, I entered this rabbit hole, and I found out rapidly that this is a huge problem, much bigger than I thought it was. It's badly misdiagnosed by our physician colleagues. And then when you add up all of the symptoms that are misdiagnosed, including Meniere's disease and millions of earaches that really are TMD, and of course, millions and millions of migraine headaches that are treated with drugs that are actually inflammation within the temporomandibular joint, it adds up to 45% of females have these symptoms. So it's a huge problem. I found out it's extremely often misdiagnosed by the physicians, and I found out what all of the nonsense that the non-surgical dentists do to try to help people with TMD, none of it long-term being effective. So that's part of the rabbit hole that I discovered. And then along the way, I began, because of what I discovered, that inflammation is the actual cause of all of these symptoms. And if you decrease inflammation, the symptoms go away. I began to see a huge number of patients, because of our referral sources, that had 10, 20, 30, 40 years of these symptoms, and either had been misdiagnosed or not diagnosed at all. But I've also seen an increasing number of patients who have been abused by the system. And therein lies the title of this episode, The Ultimate TMD Patient. So I had other topics that I could choose from for this episode, and you may hear about these later. TMD equals inflammation of the temporomandibular joint, what physicians should know about TMD, the philosophy of TMD. Yeah, everybody talks about what's your philosophy of TMD, what's my philosophy of TMD, what's the right philosophy of TMD. We'll have to define philosophy for you on that one. But today, this one was triggered by, again, a patient that I had yesterday. Today is Tuesday when I record these episodes. I see patients only on Monday. My associate takes the rest of the week. And yesterday I saw a patient, roughly 48 years old, 50 years old, female, who had had a long history of TMD treatment, and she was in to see me for care. So let me tell you about this patient, the ultimate TMD patient. As I rolled out this consultation and got the information I needed, I found the following things about her: that she was a trained registered nurse. She had a 5-year history of being treated by a local dentist who was at the top of his game treating TMD and had done so for 20 years. He used this method of recapturing the disc by placing multiple types of oral devices to pull the mandible forward and bring the condyle out of the fossa, with the theory to recapture the disc. In other words, the disc is known to be anterior, and to bring the mandible forward so the condyle can recapture the disc and put the condyle back underneath the disc. That was how he operated. This is not a one-off. There are many dentists who operate under that theory, and this particular patient fell into that category. She presented to my office with each and every one of those symptoms. Headache, currently, yesterday. Headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and literally couldn't open her mouth all the way. Various kinds of locking. She had literally no occlusion. She had end-to-end incisor position, but one of her chief complaints was, my teeth don't meet, I can't chew, there's nowhere I can put my teeth where it feels like they meet together. And this is a patient who had went through 5 years of traction of various kinds using oral devices, bringing the mandible forward, and then reconstructing the occlusion so that the mandible was held forward in that position. The real obvious thing to me as I talked to her and her significant other, who was sitting in the corner in the patient's chair, was that she was also currently under treatment by a physician pain clinic, and she was being prescribed fentanyl, and that became significant in that when I first entered the room, I could see that she was already high. You couldn't keep her from talking. She wanted to talk and not listen. But I'm here to help and try to sort this out. But that's the history that I got. So we have a 50-year-old RN who is on fentanyl, who has been treated for 5 years by this local dentist who was 20 years ago, he was the person to see for non-surgical treatment of TMD. And I knew about him. I was not friends with him, but I knew of him. I saw him at dental meetings. And I knew of him while I was treating patients surgically for my first admittedly 36 years of my career. And furthermore, as I talked to this patient, she told me that the original doctor, who has since died, was replaced, found another doctor to take his practice, but she could not see this other doctor because she owed $6,000 to this practice, which she hasn't been able to pay. So she was not allowed to see the new doctor who took the practice over since the original doctor who treated her for 5 years has passed away. A terrible problem. But the issue that I want to bring to your attention is this is what happens. This is the ultimate TMD patients that I see. This isn't necessarily the worst, depending on the circumstances. Every patient comes in with different circumstances. I think one of the worst I've commented on before is the woman I have on videotape sincerely saying that before she came in to see us, she was contemplating suicide because of the constant pain that no one could give her any solution for. So the ultimate TMD patient is not something that the profession needs to be proud of. This is my point. It is not my point to call out any particular person. It is my point to call out what is going on in our profession, in my professions, as both a dentist and a physician. And because we now have such a broad base of referral sources here in Middle Tennessee, I am collecting a huge number of similar patients. We have 800 referral sources of all kinds within Middle Tennessee. That includes PCPs, nurse practitioners, physician's assistant, immediate care clinics, dentists, oral surgeons, endodontists, chiropractors, you name it. They're included in that list of 800 referral sources who send us TMD patients to look over. And that is why, because of this broad background, I see these patients and I see them more frequently, and I'm becoming more and more tuned in to just going out and calling out our professions for what is going on here, which is really patients being abused by the system. How it got that way, I've commented before, is that I don't think anybody intentionally started out to do this, but I did comment, and my point being that somehow the road, well, I even commented on how that happened, starting out with, the seminal article by Dr. Danny Laskin talking about myofascial pain dysfunction syndrome and blaming it all on the muscles, when actually it's not. The muscles are affected by the inflammation in the joint. Yes, muscles get tight. Yes, muscles pull on bone and it hurts there, and it causes all kind of facial pains and neck pains and upper shoulder pains and creates all these symptoms. That's well covered in these episodes. But when you get to see a increasing number of patients, like the ultimate TMD patient that I'm discussing, which triggered this episode, it gets more than frustrating. It gets to the point where wherever the cards fall, someone has to stand up and speak out about the nonsense that is going on in the professions about trying to help, if some of them are sincere, actually trying to help these patients, but not using science, not using what is out there already to know. All the information that I discuss, all the information I talk about has been in the literature and known here and there, documented good science for over 60 years. It's been there. It is present. So, and then we got down to the point where I told the patient, taught the patient what really is going on, this particular patient, as I do all patients. What's really the cause is inflammation in the joint. And if you unload the temporomandibular joint with a device that simply takes the load off the temporomandibular joint, like a set of crutches would take the load off the knee, the inflammation will go away. And when the inflammation goes away, the symptoms go away. So I instructed her on this. And then, as I always do, I told her what the fee was, what the cost was, before I sent her up to talk to our financial manager. At that point, she went into her rendition of, oh, it's not covered by insurance. Well, let me tell you how we can get insurance to cover it. And that this prior practice had used some of these methods to get insurance and game the insurance company, which is another part of this rabbit hole. You know, how to pad your consultation to make it look important and add all kind of x-rays that aren't necessary, and all kind of different kinds of physical examinations that make it more complicated, and that you can then put in claims to, you know, medical insurance companies rather than just a claim for a night guard to the dental insurance company. And she went in, again, remember, she was high. She had, her intention was to have me help her, but she didn't know the kind of help she was going to get. And I can tell you with sincerity and empathy, because I had a tremendous amount of empathy for this woman. This is the ultimate end point of this, our professions, and the misuse and of bad information about TMD. So now everyone has a part to play in this. And I think everybody needs to just take a deep breath and settle down and get to the point where they're willing to accept the fact that these patients are being abused and misused and misdirected constantly. And if anyone, and I say this almost after every episode, but if anyone wants to throw comments at me or criticisms of me, I encourage it. I am happy to get into a logical discussion about what I know, but what I found out, what we do, how it works. And you know, this is going to be the 113th episode on Dental Town that I do on this topic, TMD Demystified. 113 episodes, usually running about 30 minutes per episode. I have not gotten a single comment, let alone anyone criticizing what I have to teach and what I have to say. Not a single criticism, not a single comment. And I encourage them. And I know a lot of people are watching this. I have one episode, because I look back and see how many people are watching the different titles, and I know what titles bring in more interest. And the title that brings in the most interest is the Urbanic Device and Protocol, How It Works. Excuse me, I think it's the device and how the protocol works. But it is basically, you know, how does the protocol go along with the device? And we have almost 200 views on that esoteric topic. And then a lot of other views in the 50, 60, 80 range for a podcast like this on a very limited topic, which really only dentists have any interest in it at all. I view it as, a lot of interest in this on our 113 now episodes over 2 years. But no comments, no criticisms. And you know why? Because there's nothing to criticize. If you know the science, I can point them to the science. I can direct them to the articles, the peer-reviewed articles that, document how inflammation in any joint will create muscle trismus because the joint is inflamed and it's giving instructions to the brainstem. I'm inflamed in the brainstem, so I'm going to help you out. Don't move the joint. And the muscles get tight. It is too simple. I think that's part of the problem. It is too simple for people to get their arms around. They want something complicated. They want something they can really charge insurance companies for. They want to game the insurance companies. But when it gets down to a potentially trusting patient who has taken the time to become a nurse and herself understands, I understand nurses. I used to teach nurses when I was, I'll go into that story, but, when I was in dental school, I was ahead of the game, and my interest and knowledge of anatomy was well known. And I actually got a job in my senior year in dental school because I was working on my master's degree in cell biology and anatomy. I taught nurses for a year anatomy physiology. It helped pay the bill. In fact, it did pay the bills. I was able to get through that senior year by teaching the class to a registered nurse class up in Indianapolis, anatomy physiology. There's a lot of bogus treatments going on out there. I'm going to call them out. And it's just bogus because it doesn't address the problem, and it leads to the endpoint of the ultimate TMD patient, now addicted to drugs, high on fentanyl, and I told the patient and her significant other at the time, I said that whoever is prescribing you this fentanyl is out of their mind. They're crazy. It is unjustified. It is unjustified to give you fentanyl for your TMJ symptoms. And then she is addicted. But there's these bogus treatments, and I'm going to call them out and criticize me. Show me how these even work at all over any length of period of time, when we know that inflammation in the joint causes all the symptoms. You're trying to treat some symptoms. I got that. You're trying to treat the muscles. You're trying to relax the muscles because everybody knows, this muscle gets tight and it hurts, and no one even addresses the fact that it hurts because the muscle pulls on the bone. It hurts at the interface of the muscle itself and the bone, not the muscle. Bogus. TENS treatment, myography, botulism toxin A. Everyone wants to do Botox. Botulism toxin A. Why? Because the patient is back in 3 or 4 months. And the doctors laugh about it. Dry needling from the physical therapist. Half the dentists give night guards, and no, night guards don't do anything. They know that you give a night guard to a patient that they won't damage the surface of their teeth for sure. They won't crack their molars, their premolars, but it's not going to help their TMJ symptoms. Nothing in the world stops anybody from bruxing. We do not even understand We don't understand the mechanism for bruxing. I mean, there's theories. We know, yeah, this has to do with the central nervous system. The only thing we know about bruxing is it's related to stress and anxiety. Stress and anxiety brings on bruxing. Basically, it gooses up the central nervous system, but the mechanism of how that works, how a non-physiologic emotional feeling will create a physiologic change in the body, and where that mechanism meets and how that is created, we don't know. And we don't really understand the mechanism in the central nervous system itself. We know very little to nothing about bruxing except it's related to stress and anxiety. Occlusal rehabilitation, trying to fix somebody's bite. When you're ignoring the inflammation within the temporomandibular joint. Orthodontic, same thing. Occlusal rehabilitation by multiple crowns and bridges, or orthodontics to treat temporomandibular joint, is all directed with the same theory, that if you get the bite nice and it doesn't disocclude in centric occlusion and feels comfortable, that somehow this is going to take the load off the temporomandibular joint, which it doesn't. Patients will continue to brux, or the damage that's already there is there. Basically, you have to go through and fully unload the joint. Multiple injections into the joint, steroids, what's called prolotherapy, and local anesthetics. We now know, as an oral maxillofacial surgeon, that's the last thing you want to do, is inject steroids into the temporomandibular joint. That causes more damage and degeneration of the bone itself. Psychiatric treatment to decrease bruxism. I just got notice of a major course up in Indianapolis. It's going to include all kinds of therapists, including psychiatric and psychologic treatment. Obviously inferred that, if you have anxiety, then you need to see a psychologist, psychiatrist to decrease your anxiety, which will treat your TMD. We're all anxious. We all have stress to one degree or another. In fact, sometimes a little bit of what I would consider a small stress is a huge stressor for someone else. We all have stress. And bruxism is seen in 50% of the population. You're not going to get people to stop bruxing by talking to them. And you're definitely not going to stop people from bruxing by giving them drugs. Opioids, neuroleptics, basically psychiatric medication. The number of people that I see in this practice referred in from those 800 referral sources that are on drugs of one kind or another because of their TMD symptoms is unheard of. Opioids, neuroleptics, psychiatric drugs, muscle relaxants, somnorifics, sleep medications, all inappropriate. And of course, surgery. I can tell you all about surgery. I could spend multiple episodes describing all the different types of surgery that I did, the reasons and whys about it all. I have addressed that on other episodes to some extent. But after 36 years of doing surgery and finding only 50% of the patients were really helped and 50% were back in my office within 6 months to 2 years with the same complaints, with the same symptoms, is what caused me to stop doing surgery. And I had a huge surgical practice treating TMD here in Middle Tennessee. I really was known as the doctor for surgical TMD care until 12 years ago. Physical therapy and chiropractic. Temporary relief. I've heard certainly temporary relief from each of those. Physical therapists do their dry needling and their manipulation. Of course, chiropractors have a little gun that shoots a little gun that kind of presses on the temporomandibular joint. But long-term, not effective. So what are we going to do about this? What are we going to do about this? I invite you to learn more. I invite you to watch other episodes, more of these episodes, until you find it in your heart or are convinced that there is a better way and that we need to stop all this nonsense. And I say that sincerely. I say it clearly. I will debate it with anybody at any time. The issue is nobody wants to debate me. Nobody wants to actually take a look because they have their fixed ideas, their reasons. They got the looking at this as in a way that only benefits them, not the patient. Each one of these things I talked about, it's another way to say it, is each one of these things that I discussed is really the doctors looking to benefit them. The drugs, this method of recapturing the disc, and that particular method goes on for 3 to 5 years at the cost of $50,000 or more when you get into the occlusal reconstruction at the end of it, where you got to get their teeth to fit together because their mandible's sitting out like this. That isn't what this should be about. That isn't what the profession should be doing. I'm not going to discuss the concepts of ethics. I'll just use the word. But the professions, each and every one of us in the professions, medical profession, dental profession, or any other profession, we're supposed to be professionals because we hold ourselves to a higher ethical standard. We should. And some of us do, and some of us don't. That is well known. I empathize, I sympathize, but I'm not going to ignore. I refuse to ignore. Like I told you at the beginning, this was going to be a tough one for me to do. I did not enjoy it. And if anyone would like to comment, I encourage you to do that. If you would like to learn how to treat temporomandibular joint non-surgically, effectively, long-term, a very simple type of device and procedure protocol, which gives, significant results. I won't quote them. We get patients constantly coming back that say 90, 95, 100% of their symptoms are gone. And at the end, let's end on a good point. I also had, yesterday was a tough day with patients with me. And let's end on this one. So I had a usual patient who had 40 years of, again, she checked off all of those symptoms, all of them, headache, earache, jaw pain, etc., all the way to the bottom. And I got halfway through the description of really what was going on, and the patient understood that I knew what was going on, and she looked at me and she said, "I've never had anybody explain this to me. It makes so much sense." And her husband, who was sitting in the corner, I looked at him and tears were running down his eyes. This was the first time ever. I admit it, I've seen a lot of women break down into tears when they understand one of two things: either that there's somebody else who understands the problem, or they come in for their first or second check appointment and their symptoms are gone, and I walk in the room and they're crying because they're so happy. But this is the first time I've ever seen a husband cry because he felt that his wife was going to get relief, in this case, from her 35 years of headaches. 35 years. More than 35 years, because they were married 35 years. And it was the first time I had a husband cry. I've had several of them stand up and shake my hand. I have had many women here in the South jump up and say, "Honey, can I give you a hug?" But I've never seen a husband cry. This is the first time yesterday. If you want to join this, if you want to join this group that can do this, contact us. Easy to do. Our website is www.urbanictmj.com. I can be reached at tony@tmjservices.net. My director of marketing and education, Dr. Naomi Williams, excuse me. Naomi was just married, and her new name is Williams. Dr. Naomi Williams will be happy to send you any information about our company and our service and how you can join our growing network of network providers throughout the United States and beyond. Until next time, I look forward to our next episode, probably one of these other topics I talked about. I am Tony Urbanic, and this is TMD Demystified.